When were you in Cambodia?
Oh, I was there four times, 5 times. Started in 2014, I guess, 13 or 14. I went over there as part of Health Volunteers Overseas. Did a project over there for 4 or 5 trips, trying to establish a training program there where they had none. They had no oral surgeons in the country who were trained, and the result was that they got no early care. The only things we ever saw were things that you and I would see in a textbook. In a mesoblastoma that was like 3/4 of the jaw, and extending out to the shoulder. Just never saw anything small. It was just big, because that was the only stuff that got sent into the city. And the good news was that there were some very enthusiastic young people eager to become oral surgeons. It was kind of strange. They were continuing to do their private practice in order to survive, but they came and they did their oral surgery for like half a day each day, sometimes longer if we had long operations. But it wasn't a full-time thing. They still had the need to continue their practice in order to live. And we got to the end of what should have been a 4-year program, and it was time to give the final exams. I was doing this with some people from Australia that had started it, actually. And I was recruited to be an American to get involved. And I said, yeah, sure, I'll do it. In any event, we got to the end of the time. We were scheduled to do the final exams, which were a combination of written and oral. And, those of us who were involved had all bought our plane tickets and everything else, which is, not inconsiderable, since this all was done as volunteers, paying our own way and all that.
Yeah.
So we got there, went to go give the exam, and one of the government ministries said, no, you can't give a final exam. Why not? Well, we didn't approve the program. I said, well, gee, you've been charging these people tuition for 4 years, and if you didn't approve the program. But it turned out that, the bureaucracy over there was that there were two separate. There was the Ministry of Education. They had to have their sets of approvals. And then there's the Ministry of Health that had their own set of approvals. And the two of them really, if ever, talked to each other. And so they couldn't get their act together. They finally let us do, I guess they let us do the oral exam since we were physically there. So we did the oral exam part. But they wouldn't let us do the written part. So they wouldn't actually graduate these people and certify them as trained at the end of the 4 years. They did it like maybe 6 or 8 months later. They finally relented. But the problem was you couldn't recruit new people into the program. And so unfortunately it died. So Cambodia is still kind of wanting trained oral surgeons with a great need, I must say. Tremendous need. And they're probably not alone in that kind of issue. But it was like the end of my career. I think it was the day after I retired in New Haven. The day after I retired, I left and went to Cambodia. And then the first week I was there, first day I was there, they brought in all these patients for me to see. And I saw more pathology in one day than I had seen in 2 years prior, total. And she said it all saved up. They saved up all these great cases. That I was trying to teach people who had no surgical experience, like the equivalent of trying to take a first-year resident through a commando operation. And so simple things like tying knots, that was a big deal. Learning how to tie a knot, let alone how to cut with a scalpel. I mean, they had no experience whatsoever. So 4 years later, there was some actual progress. You could really see the progress, and it was fun to see, as it always had been in my years in conventional training programs.
Yeah. Well, it's amazing when the perspective you get when you go to places like that, and you compare it to kind of what we have here in North America, and in other developed parts of the world. But it makes you kind of think about how important access to care is, and and also having all these institutions in place that having the Ministry of Health and having organizations that certify and approve and kind of going through all the hoops. And we're kind of lucky that all this has been kind of done for us. In a way, it's
so we go through the hoops of getting prior approval for this, that, and the other thing. I mean, that was true over there. You'd see somebody would come in with a big floor mouth cancer, floor mouth tongue, stage 4 cancer, but before you proceeded, you really want a little imaging, and they say, well, no, they can afford the operation, but they can't afford the CT scan. And I said, well, I'm not doing the operation without the CT scan. I mean, let's get serious here. And the government just didn't think they couldn't coordinate that kind of stuff. They might understand that they needed the CT scan, but we had to beg and borrow and steal in order to get stuff like that done. It was crazy. It wasn't it was a system of theoretically socialized care, but it was socialized non-care for a lot of the people. And the hospitals were certainly not up to the snuff that we would expect in terms of the cleanliness and sterility and that kind of stuff. It was difficult over there. But the amazing thing was we did so many of these huge operations under conditions that you and I might not think were the ideal. but we almost never had any infections. It was just incredible. We were blessed. I think there was a higher power looking over us.
Oh, that's incredible.
Whether it was a Cambodian, Buddha looking over us, or the God that you and I think of, somebody was watching over us. That's for sure.
Yeah, that is pretty amazing. Because I feel like, yeah, it's amazing how little we can get away with. I've been doing operations and for children with clefts in Mexico, and before that, I've been to India. We operated out of a closet, literally, of a maternity ward, and China as well. And the hospital in China was a little bit more developed. It was more of a hospital facility, but it's amazing, how little supplies and post-operative care we got away with for a lot of these operations where we typically keep patients overnight, 1 or 2 nights here in North America. I mean, over there, hip grafts, kids would get off the table and just walk home, with their parents.
Yeah. Amazing.
And they would do fine. I mean, because we go there every 6 months, we follow them.
Yeah.
So it's not like a hit and run project, And first, ask you just to tell us a little bit about your life growing up. What were you like in your youth, and what were you passionate about, and perhaps how did you envision things turning out for you?
Well, when I was a youth, I thought I was going to play baseball for the Red Sox.
Awesome.
But then it turned out I couldn't hit to save my life.
That was a problem.
Well, I was left-handed, and so when I was playing in Little League, none of the pitchers knew what to do with a left-handed batter. And so I think I got hit probably 2 times every game, hit by a pitch.
Oh.
So I became kind of a skittish batter. So I never did make it to the Red Sox. So I had to think of some other things. Along the way, we had a very different kind of educational system. And I tell people this now, and they just can't believe it, that through high school, I had no science, 0 science. We had at the Jesuit high school that I was at, when you got to senior year, you could opt out of a 3rd year of Greek and take chemistry. There was 1 chemistry class, maybe 25, 28 people in the senior class. Those people could take a year of chemistry. Because I never went to my senior year. Because after 3rd year, I got tabbed to go to BC on a full scholarship, so I did that. So I never had any science whatsoever in high school. And compare that with what you experienced. Compare that with my own children had. My son and daughter knew more in 6th grade about science than I did when I finished college. I mean, it was just amazing. I can remember going at one point. My daughter invited me to her high school to give a class on anatomy, on applied head and neck anatomy, to show them all great cases and stuff we did. So that was a lot of fun. But I never had that kind of experience when I was in school, so I had no idea, in terms of pre-med or science or anything like that. When I went to college, I didn't really even know particularly what a major meant. They said, "What's your major?" I said, "I don't know. What's that mean?" And they said, "Well, what do you want to do mostly?" I said, "Well, gee, I like math." So, okay, I was a math major. That's how I became a math major. It's because I enjoyed that more than anything else. Once I got into it, I realized, well, I didn't want to do that for a career. Because I just didn't see that happening. And at that point, we're going back into earlier years, 5th, 6th grade, beginning of that point, when I started thinking, maybe I want to become a priest. Maybe I want to do that for my career. So I had that in mind for all the time when I was in high school and in college. I remember my father saying to me when I was getting finished, finishing high school or in high school, he'd say, "Well, that's fine. You want to be a priest and go into seminary, but go to college first," which was great advice. It was based on his experience of guys that he knew who had sons that had gone into the seminary right after high school and then found out it wasn't for them. And when they came out, they had no training or education to do anything, and they floundered. So he was insistent that I go to college and get an education and then make my choice. So that's basically what I did. I had, during college, had suddenly realized, gee, there's a whole lot more world out there. So I decided maybe I wanted to go into medical fields. And so I took the minimum required courses. As a math major, I took a year of biology, and I took 3 years of chemistry and a year of physics. And so I had all the requirements, and I had good grades. And so I was going to make a choice about what would I apply to. And all the people who were getting the A's in organic chemistry, they were all happily applying to medical school. And the ones who suddenly were going to apply to dental school were the ones who got the C in organic chemistry. And I said, that's not that a good sign for dentistry. But I knew from the start I wanted to be involved in teaching. I always wanted to be involved in teaching, no matter what I did, whether it was whether it was in theology or if I'd gone to law school, if I'd gone to medical school, dental school, I always wanted to do teaching. And so from the perspective of medicine versus dentistry, I said, gee, I want to go into academics. It seems to me that if the people who are choosing dentistry are only doing this as a default because they couldn't make it to medical school, maybe I'd be better off if I went to dental school when I had the option to do. I could do either. I could get into medical school easily with the grades I had. But if I went to dental school, that would maybe put me on a different rung of the ladder when it came to getting prepared for an academic career. And I can remember sitting with the pre-med advisor who saying, well, you could go to medical school. I said, yeah, I know I could go to medical school. But here's the plan. And I explained what I just told you. He said, good. I told him, I think you should apply to Harvard. Because at Harvard, they have the first 2 years are identical, dental and medical. And then you can go ahead and you'll be on in that academic route and you'll be fine. And so that's how I wound up applying to Harvard. I did that in my senior year in college, got accepted to Harvard Dental School. And then as the year went on, around springtime was coming and getting time to be ready for graduation. And I said at that point, gee, I don't know. I always said from the time I was in 6th grade that I wanted to go into seminary. Maybe I should do that. And maybe I don't have the same burning desire to become a dentist. Maybe I should do it. And the good news was because I had skipped my senior year in high school, I was younger. So I was only 20 when I was graduating from college. So I said, okay, all right. So I applied to seminary, decided I'd go that route. And, I withdrew my acceptance from Harvard to the dental school. And then I went into seminary and got tabbed from there, went to the seminary in Boston for a year, and then got tabbed from there to go to Rome, to study in Rome, where Boston took 2 people every year and sent them over there to study. And when I got over there and studying philosophy and theology, I realized that was not my strength. It was a struggle. I said, gee, I can remember when I was in college, I'd take a break from history and English and stuff like that and just do math homework because it was so much fun doing math. And so I'm doing all this philosophy and theology and realizing that, gee, my real fun is science. I missed the science of doing what I was doing. And I said, maybe there's a message here. Maybe I'm getting the word that maybe my vocation is not to be a theologian. Maybe I should be something in the sciences. So that, all added up to eventually, I came to the conclusion that, my future was not to become the Pope. I don't think I would have made it to Pope because I was much too liberal for the succeeding years. In any case, so I left the seminary in Rome in my second or fourth would have been. Just went back there a year or so ago for the 50th anniversary of the ordination of my classmates, those who stayed. We had an anniversary reunion for 50 years, and that was a lot of fun.
Oh, wow.
So now I came back to Boston, and I contacted Harvard Dental School and said I'd like to reapply. They said, oh, fine, you're back, good, you're in. Just like that. So, okay, thanks. See you in September. So that's how I wound up going to dental school at Harvard. And then when I went into dental school, I was thinking, since I really like math and physics and that sort of thing, I was thinking, gee, orthodontics sounds like a lot of fun. Applying forces and making things move and, doing the architecture and all that kind of stuff. So that was what I thought when I started out. Of course, in the first 2 years at Harvard, you knew nothing at all about dentistry. You didn't even go near the dental school. You didn't know where the bathrooms were in the dental school because you didn't do anything there. And we had just absolutely stimulating lecturers at the medical school. We had the people that wrote the textbooks that everybody else used. We had the people who eventually went on and won Nobel Prizes. Just some fascinating people. Some real jerks too. Some real terrible lecturers who were very famous and wrote books, but they were just miserably bad lecturers. But anyhow, got all through all that and had a good fortune at the end of second year. It previously had been a requirement that everybody take part 1 of the medical board as a rite of passage at the end of second year. And around that time, either that year or the year before, they had eliminated that as a requirement. So those of us, the 14 of us who were as part of the medical school class, those of us who were dental students didn't have to take it. But a couple of my classmates said, yeah, I'm going to take it. And I said, yeah, I got nothing else to do that week. I'll take it too. So I did. The good news was I took it. So some years later, when the double degree program came along, I didn't have to struggle to go back and restudy and retake and try and pass part 1 because I passed it early on, which was sort of serendipitous. I had no idea there'd be any such thing as a double degree program at that point. Just took it because I had nothing better to do that week. And all my buddies were in great anxiety overtaking it. And I said, well, I'll just hang around and stay in the dorm for an extra week and, give them support. So that's how I did it. So anyhow, during the course of that time, it was when I was it was before we started in the dental school, so somewhere in my second year. Dr. Grownick, Walter Grownick, who was the chairman for many years, he had lots of great connections dating back to World War II and when he was in England. And he invited Norman Rowe to come to Boston to do a continuing education program for a week. And Dr. Grownick invited any of our students who are interested to come to the lectures. And it was Norman Rowe was talking about applied surgical anatomy. Now here I was thrilled with anatomy after my first year as a student. Absolutely loved anatomy. I got thinking, gee, there's a lot more to this than just moving teeth with wires. Maybe there's something more than orthodontics. So I didn't know what. Then I sat through these lectures with Norman Rowe, and he came in and he'd give a lecture on the anatomy of the orbit, for example. And pretty dry lecture about the anatomy of the orbit, this bone and that bone and this, this muscle and so forth. But then he followed that with the applied surgical anatomy. He would show all these great cases of facial fractures and how you fix them, and how you evaluate them and how you fix them and all that kind of stuff. I mean, it was just absolutely mind-altering for me. When I said, I got through that week's worth of lectures, I said, that's what I want to do. I want to do surgery. And then that got further stimulated by starting third year at the dental school, where we had these 2 years worth of lectures by Nobel laureates and textbook authors and all this kind of stuff. I get over to the dental school and, got told about line angles and Gracie curettes and, how to make a denture and that kind of stuff. How to cast a crown. Most of us cast jewelry for girlfriends at Christmas time. But at the same time, we had our series of oral surgery lectures, which were the only lectures that we had in the dental school that even came close to holding a candle to the type of lectures and stimulation that we got for the first 2 years when we were with the medical students. And it was just totally fascinating to me. And not only to me, of the 14 of us in that class, 6 went on into oral surgery. And that's the kind of influence that Wally Grownick had on us. And it wasn't just him, but it was largely him, but also his leadership and the people he brought in who were members of the faculty. The fact that we had a requirement at Harvard, we all had to do a thesis. We had to do a research project and write a thesis. And a good number of my classmates worked with oral surgeons doing their thesis. Lenny Schulman was doing the earliest stuff on implants, before anybody knew anything about implants. He was doing things on transplantation of teeth and that sort of stuff. And Tom Intrasano, who just recently concluded his career as the president of AAOMS, he was my classmate, and he did his research project with Lenny Schulman on tooth transplantation. I was in the lab doing what turned out to be molecular biology. Didn't understand it at the time, but that's what it turned out to be. I was doing biology with cell cultures and suppressing tumor genes and that kind of stuff. But anyhow, we had all these other stimuli, and the most stimulating thing for all of us was oral surgery. And then we had an interesting curriculum at the time, where we had the traditional dental clinics in third year, where you're in the clinic and you did perio one day, crown and bridge another day, and operative another day. And then in fourth year, it was all elective. Not all elective, it was all rotations, clinical rotations, similar to what medical students did. And one of the rotations was a solid month of oral surgery at Mass General. And Harry Schwartz and I were together. We went 2 students at a time. And Harry and I went there together. Harry went on to become an oral surgeon, practices, as you know, out in California. So he and I were there together as students. We also spent 3 months together doing our restorative dentistry rotation at a VA hospital. So Harry and I spent a lot of time together, became great friends. And then ultimately we were both accepted to the oral surgery program at Mass General. So we were running mates at Mass General too. But anyway, that's the kind of exposure that I got to oral surgery. And I, along with others in my class, obviously, had oral surgery high on our list of things we wanted to do. When I started residency, it was the mandatory 3-year program. And that program included mandatory time on medicine and mandatory time on surgery. And it was actually another famous name in oral surgery, Lenny Caven, was one of the ones who stimulated all this, because he was on surgery. And when you're on surgery, sometimes they throw you a bone if you were really a good guy and you had done a good bit of work, and they let you do something like an appendectomy. With a lot of help and guidance, of course, but they'd let you do it. And apparently Lenny did that. And somehow or other, some patient was looking at a dictated op note, saw that the guy that had done the surgery was a DMD. And they wanted to know, how come a dentist is taking out an appendix? So somebody was raising some stink about it. And so Dr. Grownick was really convinced that a general surgical background was necessary to do the kinds of things that we were suddenly doing now that hadn't been done 10 years before. We were doing osteotomies nobody even thought about doing. We were getting involved in reconstructive surgery and in cancer surgery that nobody had been doing 10 years before. And so he thought it was going to be very important to establish not just a 2-month rotation on surgery, but to establish a good surgical background. And the only way he could achieve that was for us to get a medical degree so that we could function as surgical residents. And that was his motivation, to get us a medical degree so that we could then do oral surgery, do general surgery as a core, and be the equivalent of the guys who were going into urology or orthopedics or ENT, who had a core of general surgery before they did their specialty training. So that was the plan. And I was in the right place at the right time. First year of my residency, I walked through the lobby of the hospital on the way to rounds one morning, and he grabs me and says, "Hey, you want to go to medical school?" I said, "I don't know what." He said, "Yeah, next year you go to medical school." I said, "Oh, okay." I only found out more about that, some hours or days later. But that was my introduction to here's what you're going to do. And what happened was that at that time, Steve Rosa had finished a year. He finished residency right when I started residency, and he had been agitating for getting more training, and he had applied to medical schools all over the place on his own. And then when Dr. Brown got this thing going, he was able to get Steve into the medical school at Harvard. And then Bruce Donoff was already on faculty as a junior person. He got him on. Lenny Caven and Ed Selden were my chief residents, and they finished their 3 years. They went back to medical school. So they were all doing it after the fact. Rosa, Donoff, Caven, and Selden all did it as an appendage to training, where I was the first one to do it as planned, to go at the end of first year and go into medical school, spend a year doing all the clerkships, the 3rd-year clerkships. And then the 4th year at Harvard Medical School, at that time, the 4th year was all totally elective. And so my elective was to be a surgical resident. Actually, that year was a split year. It was half year as a surgical resident, half year as an oral surgery resident. And so I got full credit from the medical school for doing that as my 4th year. That's changed a little bit as time has gone on, but that's how it worked out. That we became, I was considered a medical student for 2 years, but one of those 2, I was simultaneously a resident at the hospital. So that's how that worked out. And I did, I finished that program as the first one to finish it as planned. Harry Schwartz, my running mate, he did the 3 years, and then he did the medical school and the surgical resident here at the end of that. I actually got 18 months of general surgery, where the people did the appendage for only getting 12 months of general surgery. So that's how that all worked out. And it worked out pretty much as Dr. Balnick planned it, that, we got this great experience on general surgery. I mean, there was no question when I came back onto oral surgery after spending some horrific days and nights as a cardiac surgery resident, man, there was nothing that scared me. Absolutely nothing. You get somebody nicks a little facial artery or something, you get a spurt of blood. Nah, big deal. I've seen aorta. What the heck? I mean, I'm not going to get excited about that. Just keep calm and just take care of things. So that was a great experience. And the things that I learned during that period of time on how to take care of patients and how to apply certain things that you learned applied anatomy and learned tissue handling when you're doing a hernia, but then you could apply that to the fascial layers and things when you were doing things in the head and neck. It was a great experience, perfectly great experience. I wouldn't have traded it for anything. Any more than I would have traded my experience, let me backtrack, and I wouldn't have traded my experience in the seminary. To learn things about my religion that I didn't know when I was growing up and just going to Sunday school and going to church, and coming away very committed to what I learned because I was more knowledgeable about it. So the same thing applied now with surgery, applying that when I was a chief resident, and having learned from good mentors and bad mentors. I mean, there were a couple of, there was one particular guy I'll never forget who taught me how to tie knots. And I taught you how to tie knots, and I taught everybody. So you got to learn how to tie a knot. And don't give me this nonsense about a two-handed knot. Show me, a one-handed knot. Show me how you tie a two-handed knot perfectly, a nice square knot, and do it every time, and do it without hesitating. And what the fumbling that went on with that. I mean, that took some time. But I had Dr. Wong, who did nothing but thyroids and parathyroids. He was absolutely a master, but an exquisite surgeon. And I was with him for 2 months. It was just a fantastic experience. And he would let you start off doing absolutely nothing, basically, but sponging, just blotting, holding a retractor. And then the next time, maybe he'd let you make the skin incision down to the subview, and that was it. And then maybe you'd progress, and pretty soon you could put the clamp on a bleeder. And then big step was tying the knots, and he would teach you how to tie a knot, and you got to tie hundreds of knots. And if you did it well, okay, then the next time you progressed, you got to do a little more of the cutting, then you got a little more of the clamping, and you got a little more of of the tying the knots, and then progressively you got to do the closure, and then you could close this layer, okay, and now you close that layer too, and it was step by step learning, and it was just a phenomenal experience that I tried to carry over when I was in the position of being a teacher. And I know it must have been a pain in the butt for me to say, here, tie this knot, when everybody wanted to do their instrument ties. And then they would fumble because they couldn't tie a bloody knot. But there were times that you had to know how to tie a knot.
Yeah.
So, but I had him as a great mentor. Some other people when I was on general surgery who were just terrific at being supportive. From the very beginning, I knew I wanted to teach. They said that was one of the reasons why I decided to go to dental school as opposed to medical school, because I wanted to teach. And the reason I wanted to teach was I always had this feeling that providing care to people would be a great satisfying thing to do. But I realized that one-on-one you could only influence a limited number of patients that you could take care of. But I always saw teaching as having a geometric component, that I could influence the care of far more patients by educating residents who then would go on out, so that each year I would have a geometric influence on people. And that was certainly true in the days of Mass General, when people not only went on to finish and go out, but many went on into academic careers, and then it became another geometric progression. And so as with you, as you go into academics, as you now I'm having an influence on your trainees, because you're providing training to more and more people. And so in a way, that's sort of like the genealogy. It's the what's it called, ancestry. the tree of the influence that my going into academics, well, Walter Groundler going into being in academics and influencing 6 out of 14 people in my class to go into oral surgery, and of those 6, 4 went into academics and had an influence on another generation of trainees, et cetera, et cetera. So that whole idea of having a geometric influence on delivery of care, that was what put me on the track to wanting to do academics.
Yeah, that's really one of the cool things about teaching. And I even though I definitely also learned a lot in my fellowship, there's a lot of things that I do that you taught me, and sometimes the residents ask, like, why do you do it this way? I'm like, well, this is the way Dr. Kelly did it, and here are the reasons why. And it's funny because even some things that I protested doing as a resident, I've gone back and say, no, actually, I like the way John Kelly did this. And I was like, oh, wow, I was a real pain in the butt. But, there are a lot of great things you pick up. Even, when doing orthognathic surgery, it's interesting because these days, most of our residents have not done model surgery. There was a time that we still had them do model surgery, and we would do the computer-assisted surgical planning. And really, as time went on, residents stopped doing model surgery and we stopped requiring it. We're just so used to the current digital workflow. But the residents, have a greater appreciation of like anatomically what's happening with the 3D planning. But if your splint doesn't fit or something isn't quite right, there's kind of this "what do we do" feeling in the room. And I had those situations several times, and the residents kind of looked at me and I said, well, and I had one case where I just pulled the maxilla forward and just held it there, and they couldn't believe that you could just hold the maxilla kind of where you think it needs to be and just plate it, which I said we do this all the time with Dr. Kelly. And I had another patient with a sleep apnea case where they had reversed the splints. The intermediate splint was for a Lefort first, but the case was actually a mandible first case. It was a large advancement with somewhat of a counterclockwise rotation. And so this was actually not long ago, maybe a year and a half ago. And I just had the residents get some blue mousse, and I just held the mandible where, roughly where we had planned it to be relative to the maxilla. They filled in the blue mousse, and then we, it kind of set, and we wired it into place and we plated it. And, one of the chief residents who was operating with me said, why don't we just do this all the time? I said, I'm not sure I can get it just right every single, 10 times out of 10, but that's one of the cool things about having varied training and seeing different ways of doing things, because you can get yourself out of these types of situations where somebody else would think like, wow, we're kind of doomed right now.
Yeah.
So
well, I know I saw some results I saw over the years that I questioned, orthognathic cases that say they must have treated that one to the splint. Because when I was in Long Island, there were people who were doing surgery and working with an orthodontist who used to give them the treatment plan to, I forget what it was, to the 10th of a millimeter or 100th. Might have been just the 10th, but that struck me as kind of crazy. You got to advance advance this 4.2 millimeters and the other side 4.4 millimeters, and think they could actually do that. But they, they insisted that's how they were doing it and planning it. And then he would make the splints, and they would treat it to the splint, and I'd see the result of it. I can remember the first person I saw when I went there was one of these nurses that was in our OR, and I said to Salvadero, I said, Sal, she'd be a great one for us to operate on. He said, that's a post-op. I said, oh, sorry.
You've had a long and successful career, and of the many things you have done in your career in life, what has been the most meaningful to you?
Well, I think it was the totality of all the things I did in terms of residency education, because that was my goal from the beginning. And then I was fortunate enough to get into positions where I could do things that I think had some lasting effect. One of the ones that persists to this day, and I think was important, was the institution of the matching program. And when I first started out, there was no such thing as a matching program. There was free for all. People, making, there was a gentleman's agreement date for acceptances that was just completely ignored and abused, where everybody said, oh yeah, I agree to this date of January 15th, but they would be making offers to people on November 15th. And I was able to do a survey to demonstrate that, and I was able to show the assembled group of oral surgery program directors, all of whom said that they adhered to the agreed upon date, but then showed that 75% of the incoming first-year residents had all received their offers before that date. And so then I talked to them about looking to their left and their right in the audience and say, did that guy cheat? Did he steal your resident when you were hoping to get the guy? So that was, people realized that nobody was adhering to it, and I was able to put that matching program in place. And it, as you experienced it, it works perfectly. I don't think there's any glitches in it whatsoever anymore. Started out with a couple of glitches, but it worked out. So I think that was something to get oral surgery residency into the mainstream, where I had the opportunity to consult with the people that ran the medical match, and so I was able to use their experience and expertise to get it going for us. And then beyond that, I was in a position I chaired the committee that rewrote the training standards when we wanted to go from a 3-year program to a 4-year program. And I basically wrote that document and certainly edited the final version of it, which I think was a major, an attempt to really expand our training programs to include much more of what we would do today, contemporary. When the contemporary was still talking 20 years ago. But this was at a time when there were a very small number of double degree programs, but everyone recognized the need for a solid amount of medical and surgical training as part of oral surgery basic training. And so that was key to getting it in. We had to go to a 4-year program in order to get the amount of oral surgery training that we needed, given the fact that we were doing major surgery now, but also to get sufficient time to get a meaningful amount of medicine, a meaningful amount of general surgery. Not ideal. I mean, the ideal was to have a year of general surgical training, but at least we were getting more in than you could get in the old 3-year program, where it was sort of a quick little medical school type externship where you didn't do very much and didn't have any responsibility. So we increased the number of months you needed to do. We increased the amount of anesthesia that one needed to do, and that's even today a big issue, as you know. But I think my opportunity to deal with that was something I really treasured. Later on, getting asked to be the editor-in-chief of the oral maxillofacial surgery updates, that the first 2 volumes of that I was the editor-in-chief. I think that was an attempt to really expand the continuing education component of our specialty. Kind of interesting. I remember when we were doing that, we had just about finishing the first volume and getting ready for the second. I can remember going to the people on the board of trustees at Amos and saying, there's this new technology coming about. And instead of printing this in hard copy with great big 3-ring binder, we should do this new thing and put it on disk so that people can do it on their computer. And that got soundly defeated. I was laughed out of the room saying, no, that'll never work. Nobody's going to ever do that. But now look at it. What do we do now? Does anybody look at it, the 3-ring binder, or do you go to Google and look stuff up? But that was something that I only wish I could have accomplished back then. Didn't do it, but I thought about it, and it's kind of a shame. Now I think most people would do that. Even on textbooks, you get the textbooks on disc when you get the book. And that's how people look things up. But I didn't get to do that one. And then my opportunity to serve on the board as an examiner. I think that being an examiner, that week that you spend with your colleagues is one of the most rewarding weeks of the year, where you hear you learn a lot of things, and you get to meet all the new candidates, but you learn an awful lot from your colleagues that are there in a way that you can talk about it better than you can at an Amos lecture with 1,000 people in the room. There's not a whole lot of interplay in those things, but when you have a group of 30 or 40 people and somebody's giving a lecture, you can certainly question anything along the way as they give the lecture. So it's the interaction that takes place during board week, I think, is phenomenal. Then I had the chance to, as you know, to move up the chairs and on the board of directors and try to upgrade the exam every year. We tried to do something to make it better. And that my successors over the past 20 years have done much the same, trying to make it better. I don't know if it's always been the case that we made it better. Sometimes we had to reverse. We went into a period of time where we were doing case presentations because we thought that would make it better. Where instead of grilling you about an unknown case, we could have you tell us about an interesting case you did, and we could talk about it and go into detail of it. That sort of fell apart for a lot of reasons, but among the reasons was that people weren't doing any major surgery. They were submitting, as their experience in reconstructive surgery, they'd submit a case of 2 implants and a denture. And that kind of limited how much we could ask them about. But that was the cases that were being submitted weren't very good. The ones that did submit kind of really interesting, complicated cases, turned out they would always say, well, no, I did that when I was a fellow, and it wasn't my decision to do that. That was the fellowship director's decision. So we got rid of that case presentation part of the board because it just didn't work. It wasn't doing what it was meant to do. It wasn't making it better for the candidates, and it certainly wasn't making it any better for the board to evaluate the readiness of the candidates to be certified. So they're making new changes again in the board with the distribution of the categories and that sort of thing. But there's so much going on in contemporary oral surgery. I think that's one of the questions you're going to get to ultimately. But there's a lot going on, and people aren't doing the kind of things in their daily practice that we expected them to be doing 20 years ago.
Well, those are some really huge accomplishments, and I'm sure we're very time consuming. And I think a lot of us would agree, we're very thankful that you spearheaded a lot of these initiatives and were part of kind of making it what it is. The past, the updates, the board exam. So I think those are all really cool experiences. And I actually am not a board examiner yet. It's something I'd like to do in the future. Currently, Brent Ward, who's our chair, is the board examiner. And he told me it's a great experience. He recommends it once I have a little bit more free time, because it does, take up quite a bit of time away from family and such. But what has brought you the most joy in your career, or what have you enjoyed the most?
Oh,
maybe this is repetitive.
No, but I enjoy the most is seeing the outcome with residents, and the joy of seeing people who finish residency and go on, whether they go on into an academic track like you did, or whether they go on into a practice situation where they become leading members of their community in a private practice setting, and stay involved in oral surgery. I'm thinking of somebody like Mark Sikowski, who finished residency and went up into a private practice in Maine and became a very well-respected member of the practice community there, but also stayed involved and ultimately went on and became a president of the American Board. So the fact that somebody like that does really a lot what I did when I was finishing, I wanted to try and follow in Walter Groundlick's footsteps and try and make as many contributions as he had done with committee work and trying to do things to foster residency education and that sort of thing. So when I see that happen, that's my greatest source of joy. I think we talked about last time how I wanted to go into a teaching mode of activity in order to have that kind of a geometric effect, not have an effect on one patient at a time, but to have an increasing number of patients who benefited from whatever I did. And so, seeing a resident go on and be very successful, and being an honest practitioner, and being a successful practitioner, and then others going into academics and pursuing that route. Some people going some go into academics in a delayed way, which thrills me. To see somebody like Sugi, who was basically in a private practice situation, and now going into an academic situation, and that really excites me. I think that's a great thing. So yeah, those are that kind of seeing the outcome is what really excites me the most.
What would you say was maybe the biggest challenge you faced while teaching residents?
Oh, I think that was when you think back on it, I'm sort of a little bit biased by having just finished Mort Goldberg's book, but he just reinforced things that I already thought. The biggest challenge is that the change that occurred, it sounds like an old guy saying, these young people are no good. But the fact of the matter is that people did change during the course of my career. When I was a resident, we had just extraordinary peer pressure to know more and do more. We had the pressure of going on rounds in the morning and needing to know exactly what had happened with that patient overnight, and being able to present it to someone, and being able to answer the questions about, what do we do next and why do we do it? And that was peer pressure, not from faculty. That was peer pressure from the resident a year above you and from the chief resident a year above that. And it wasn't bad pressure. We didn't resent it. We sort of knew that was how it was done. But you've made rounds and you see how, well, they don't really want to spend time and go to the library or go to the computer at night and look something up. They'll just wait for you to tell them the next morning. But there was I think, a major shift in what we expected of ourselves back when I was a resident and what we expected of residents when I was a junior faculty. And it got to the point where you couldn't expect that because they weren't going to do it. They didn't want to do it. The idea of, every other night, every other weekend, I can remember changing that kind of a routine because I realized that just because I did it didn't mean that everybody after me had to do it. So when I became a program director, I tried very hard to change the call schedule so that people didn't have to do that kind of a silly arrangement. It was subsequently realized not to be in the patient's interest or the resident's interest when they go to 80-hour work rules and all that kind of stuff. But long before that, we were trying to change so that you could accommodate people who now had families to deal with. But the pendulum swung the other way. There were many residents that just they didn't care. They were 9-to-5ers, and that was very distressing because it was really hard to get people to, self-motivate and educate themselves. I can remember going to the library and looking up stuff and trying to, fill up index cards so the next day I could talk about whatever it was that this particular patient had. People really did that, as you know. Hardly ever did people do anything outside of the 9-to-5 time. So that was a kind of a disappointment as we went along. But
yeah, certainly not true of all residents, but it is surprising when you see folks who are trainees and who if they're really their chosen profession and they're not really investing the type of time and energy that will allow them to have true expertise in their chosen profession. So that is surprising, but I think sometimes that tends to stand out a little bit more than many other trainees around us who are really prepared and are putting in the time. But maybe that goes back to really figuring out how to select the best candidates during interview time. But certainly a challenge for every program.
Well, a lot has changed in the way oral surgery practices, and I was in the right place at the right time as oral surgery was expanding like a giant weather balloon, where the Walter Groundlicks and the Harvey Walker and the giants of the time were expanding what oral surgeons did to the point where they had to change the name to oral and maxillofacial surgery. And that wasn't just window dressing. That was because what used to be oral surgeons who used to do office-based practice and then go in the hospital every now and then to take a tooth out on some medically compromised patient, it became, as you know, oral and maxillofacial surgery with major operating room cases and expertise in areas that our colleagues would call upon, far beyond taking out a little wobbly tooth in a patient who's going to have cardiac surgery the next day. But now look at what people do. People get finished in training and they just want to go in the office. They don't apply for hospital privileges because they don't want to have to take call. And so it's really a waste of time for them to spend 6 years, I think. But it's unfortunate because it changes our whole complexion of what we do. And when you have a community full of people that don't take call, it hurts the guy who say somebody like you who wants to do full scope oral and maxillofacial surgery, who wants to keep working in that expanded milieu that we got to know and love. I got to be there at the right time when we started. We're really just starting orthodontic surgery at the time. We didn't do total maxillas when I first started out. They were doing sagittal osteotomies and vertical osteotomies. That was it, and the occasional anterior segmental for maxillary excess. But it was during my time as a resident, right at the end of it, when we started doing the Fort 1 osteotomies. It was during that time when I was a senior resident and then junior faculty that we were always going to the head and neck tumor clinic, but we never did very much. But all of a sudden they said, well, you take the maxilla and you move it around, right? And I said, yeah. I said, well, why don't you just do this one and just throw it away when there was a maxillectomy that was needed. And they recognized that we were doing things that, could expand. And so that's how we started doing tumor surgery at Mass General. So we got invited in because they knew we could do it. And we showed we could do it. We were intent on doing it. We were devoted to the time you had to put in to take care of those patients. Now, I just don't think that's happening in a lot of places. And I think it's a shame, but I do see a two-tiered type of oral surgery that's going to come about. There's going to be oral surgery, the office-based people, and then there's going to be the surgeons, people who do take call when a crunch comes in, people who do take care of a tumor, people who do take care of, an osteotomy that needs to be done. I don't think the guy who's going to be sitting in his office doing teeth and titanium, that somebody gets a pragmatism. I don't think that person should be doing one orthognathic case a year. I don't think that's in the patient's interest at all. But that's a bit what was being done. But I don't think that happens much anymore. I think even those people say, no, I don't do this kind of surgery. But I don't know where they send them. That's the problem. And we don't have a happy two-tier system. We have a two-tier system, but it isn't necessarily collegial. I think we've got to bite the bullet, recognize that there is a two-tier system, and then figure out how to make it work better.
Yeah, I feel like I have, I agree with what you're saying, and I have a bit of a positive spin or view of the whole thing, in that, we probably have the largest number of fellowship trained head and neck and microvascular trained oral and maxillofacial surgeries now than we ever did. It's amazing the number of people I meet that have this specialized training. We have probably the largest number of pediatric craniofacial fellowships and pediatric trained oral maxillofacial surgeons than we ever did, in a formal way, and several other fellowships. And I feel like, for many of the private practitioners, who they are providing a great service to the community, there's a difference taking trauma call for them versus for someone like myself, who I have a team of residents and folks that, can see the patient in the emergency room, can get an H&P, can get that patient set up, and, can round on the patient after surgery. That's a different level of commitment. And I come in, I get to do the fun part with the residents and do the operation. I got a team of people. We got people to retract. So I feel like, yes, if I was in the community, I would love to keep doing trauma. Maybe that's just a personal desire, if I was a private practitioner. But there is a difference in the level of time commitment and the amount of support that you have being in a residency program and taking that trauma, versus if you're out on your own as a private private practice surgeon. So I do see both sides of it a little bit too. And I think there's a lot of great service to the community that's provided by private surgeons that I don't provide. So I think hopefully everyone kind of contributes to the overall puzzle.
Well, we're not alone in the evolution of practice. So we look at internal medicine. I don't know about around your way, but around my way here, the number of people that are hospitalists is phenomenal, and the hospitals function with hospitalists taking care of the inpatients in medicine. And so the outside community physicians send their patients in, and somebody else takes care of them, so that they don't have to come in to the hospital in all hours of the day and night. Somebody's taking care of them for them, and then they get them back at the end. So the practice of medicine has changed a lot. And the guys, our colleagues who are in the office with a full schedule of patients of teeth and titanium, they either don't or won't or can't cancel that to go to the OR to take care of a mandibular fracture, who comes in uninsured and unpaying and all that kind of stuff. And they just don't want to do it. So that leaves an opening for the hospitalist oral and maxillofacial surgeon. But that's kind of hard to implement nationwide in all the hospitals. We still rely on people in some communities are going to have to take care of those patients.
Yeah.
You saw in New Haven how many times when one of the private attendings was on call, they wouldn't want to do a fracture until after 5 o'clock. That created havoc for trying to schedule things in the OR, created havoc for taking care of the patients, created havoc for the life of residents who, they couldn't go home at a reasonable hour. And it was kind of crazy.
Yeah, and I think it points to, there's some individual factors, but for the most part, I think, the shift in practice that you're describing, I think points to systematic factors that and financial pressures and market pressures and all that contribute to kind of the root cause of why things are the way they are.
Right. Yeah. But I think we have to be aware of these changes, and we have to sort of be in a position to figure out, answer the major questions. Are we going to have a two-tier system? That's a basic question that people are unwilling to answer at a political level, in the leadership of organized oral surgery. They don't want to talk about that question. But I think it's a question that has to be addressed. And then we have to address it at the training program level. Do we in fact need, do we need more, do we need the programs to evolve into a double degree for everybody? I think the answer to that probably is being answered for us on the streets. People are answering with their feet, and the answer is no. A lot of the people coming into oral surgery want to train and prepare for the teeth and titanium in the office practice. And we have to, it's our job to maximize that. If that's what it's going to be, we want to make sure that the kind of oral surgery that's being practiced is at the highest level. I look at your training and my training. If I were just taking out wisdom teeth, I could be very satisfied. I love doing wisdom teeth. I had a great time doing it because I think I was taught very well how to do it. And I was, always happy to have a patient come back and say, gee, that was bad. That wasn't bad. That, I remember my brother had him done a year ago and he was miserable. But this was really good. And that made me feel good. And, so make me say, okay, let's do some more wisdom teeth. But I also knew that if anything happened in the course of that removal of the wisdom tooth, some kind of big bleed or you name it, something happened to me, then my training stood me well, that I was not going to be flustered by that. And I could keep my cool and go ahead and bail out of whatever this sudden complication was. Because I think we said last time, once you've dealt with the open heart surgery patients and having those crump on you in the middle of the night as a resident, there's not too much that scares you. Certainly not when you're taking out a wisdom tooth. It's not going to scare you, and hopefully you're going to be able to utilize the skills and the sang-froid as it is to provide the best care. So even if we go to a two-tier system, it's going to be our responsibility to make sure that tier of office-based oral surgery, make sure that that's provided at the highest level of care. And then we also have to make sure that we utilize all those people you're talking about that are fellowship trained, and some that are not fellowship trained, but also very well trained, to make sure that their skills get recognized and utilized, and that their skills expand, so that our contribution to our society becomes more and more important.
Do you feel like you're able to achieve work-life balance between your professional and personal life? Maybe if you can comment on that, both early on in your career when you're probably doing a lot of things, and later on in your career when you're also doing a lot of things, and as life changes. And what do you think about that, achieving that balance for current trainees and graduates?
Well, different phases. If you look back at residency, when I was working every other night and every other weekend, there wasn't much balance at all, because when you'd come home, you'd be dead tired and fall asleep. So the home life was miserable. Then you'd miss all kinds of family functions because you just physically couldn't be there. You were on call. So not much work-life balance existed for residents in my day. A minority of people were married. Very few residents were married in my day. And those that were didn't do very much. You didn't have much time off to do stuff. You didn't have a whole lot of vacation. Even if you had a weekend off, your weekend consisted of not being off until anywhere from, if you're lucky, 8 a.m. Saturday morning, but more likely 10 a.m. or maybe even noon when you got off. Then you were back on Monday morning at 6 or 7. So you really didn't have a whole lot of time off when you had a weekend off. And you spent a good part of that just trying to catch up on sleep. Going into practice and starting on faculty, it was better, obviously, as you got to be home more. But there were all kinds of things that I can remember spending nights, many, many nights after eating supper, sitting in at my desk at home, measuring cephalometric films and all that kind of stuff, and trying to do research projects I didn't have time to do when I was at work, and spending many, many hours doing that. So that was not a whole lot of balance then. It was better, but it wasn't. In residency, at least, people have changed so that the work hours are different. So I think people do have a sense that they can have a life of some sort outside, not the same life that their friends who are accountants and bankers can do, but still better than it was back in the day. But I don't think it's much different for junior faculty or even senior faculty than it was then, because if you're going to be faculty, you have to be doing productive educational things, whether it's preparing a lecture or trying to do a research project, writing a paper, or editing paper. I did a lot of editing, a lot more editing than writing, even though when I did write, it took a lot of time. Like that, you probably remember that selected readings about various kinds of flaps in oral and maxillofacial surgery. That took me a whole year reading and writing to do. That was very time consuming, and all of it done at home, not done during work hours. Um, as you got more senior, you had more help. You had more junior people to do some of the scut work, so you did have more time, and that sort of coincided with, when you have children and the children get old enough to do things, with. I can remember the first time I bought a cell phone, one of those great big behemoth of a cell phones that they originally had. But I only bought it because my son had gotten to the age where he wanted to try to play golf. And I knew that if I was off on a Sunday and I went, or if I was on call, if I went to take him to the golf course, then undoubtedly my beeper would go off somewhere as far away from a phone as possible. So that's why I bought a cell phone, so that I could at least, go out and do things with my son and not get it all interrupted by a beeper going on. That I never actually had to use that cell phone while playing golf, by the way. So it worked out. But though, I did get, in time, you got so that you could do much more balance. What wasn't balanced for me in all those years, I got so involved with things that so much of my time away from the office, time away from the hospital, was at meetings and travel of business type sorts, that almost all the trips I took, even with family, were related to oral surgery meetings, whether it be a board meeting or an AMIS meeting or whatever. Almost all my free time was spent doing that. I didn't really feel I had time to take a week off to go to the beach, because I, had taken a week off to do a board exam or taken a week off to do some other meeting, that kind of stuff. So there probably wasn't a balance there. I look back and say, gee, my kids did get to see a lot of interesting places because we went on board trips that once a year we went to a place that was really interesting to bring your family. But still, there were a lot of things I didn't do that I wish I'd had a chance to do back then. These are a lot of things that I figured I might get to do in retirement, which for a lot of reasons, medical reasons a year or so ago, and pandemic reasons this year. Hard to travel, hard to do all those things that I said I wanted to do. But time will come. It'll happen. But I guess the balance, it was difficult. And it was not just difficult for me and for my colleague surgeons, but it was also difficult for their families. I mean, some families did better with it than others. No question about it.
Yeah. Well, I really appreciate you sharing that. I find the balance to be extremely challenging. And, I think right now, I think kind of before we have a young boy, he just turned 4, but before having a child, it was, as soon as I'd be done with dinner, back to work, kind of like you're talking about now, at least forces me to take a few hours to spend some time with him.
Sure.
But still, with all the travel commitments and everything, and you get to ask to be part of a lot of really interesting things in academics, and for us, it's like it's super fun to be part of all these different initiatives and research projects. So it can be hard to say no to things, and you can fall into a pattern of overcommitting to so many different things. And I guess I learned an interesting or an alternative way to kind of think about that, and it's from Paul Soderno, who's the chair of plastic surgery at Michigan. And one of the kind of junior faculty development days, he spoke about kind of that work-life balance, and he said that, think of it this way: every time you say yes to something, you say no to something else. Everybody knows that, the opportunity cost. And consider the fact that you might be saying no to your family when you're saying yes to another project or some other endeavor. Maybe it's a quality improvement project, whatever it may be in your hospital and a national office. You're taking that extra time away potentially from your family. So I think that has made me think more carefully about saying yes to things, knowing that, well, I don't want to say no to my family. I know, but no, I don't think anybody does. But it's just a good way to think about it before you commit to something.
Sure, you're right. But fortunately, there are people like you that are committed to doing it all. We need that.
Yeah.
And you're in an environment, you're working with people that I know well, who also are committed to that, committed to quality education, but committed to their families, committed to life. I think that's, ideally we'd all be like that. But that's ideally. We know we're not in an ideal situation.
Yeah. Well, you mentioned I think we all know that you were part of the team of doctors for the Boston Bruins. What was that experience like?
Oh, that was great fun. I did that all together. I did it for 25 years. But I started out, I had been a hockey person from grade school on. I never knew much about basketball, being 5'6" at my best. Basketball was never my game. But also in Boston, you either were a fan of basketball or a fan of hockey. Almost never both, even though the Celtics were champions.
Really?
The Bruins. Oh yeah, I was an avid Bruins fan from day one. And so at one point in the locker room at Mass General, the surgical locker room, this guy who was the orthopedic surgeon was the chief. I guess he's like the chief medical officer for the Bruins. Came up to me and said, "Hey, do you guys want to cover the Bruins as team dentist?" Yeah, sure. Because this guy, turns out, he didn't know anything. He didn't know the difference between a dentist and an oral surgeon, but that's okay. We quickly straightened that out. But anyhow, he said, sure. So the idea was there were four of us who were going to take it and cover each game. It required going to the game, getting there early, and going there, staying after the game, and taking care of whatever came up, and then being available like on call in between games and that sort of stuff. So I went as totally as a fan, and so the other guys went as an obligation. And the only time that the other guys went to a game was if I was going to be traveling and I couldn't go, because I went and what, like 82 games. I went to 78, I think. The first, no, 70 games. I went to 68, something like that. And the very first game I went to, I didn't know. I just had, they gave me the tickets. I went, they gave me 2 tickets, beautiful seats, perfect seats. So I went to the game first time, sat through the game, went home. I didn't know anything. The second time I went and brought my son, and halfway through the first period, there was this big crash collision right in front of us. And then this big pool of blood on the ice. And the trainer holding a towel to this guy's face as they took him off the ice. And my son said, "Gee, Dad, I think I need you." But I didn't know anything about where I was supposed to go, what I was supposed to do. But a minute or two later, this young assistant trainer comes and taps me on the shoulder and said, "Are you Dr. Kelly?" I said, "Yeah." And he said, "Well, come with me, they need you." So that was my first introduction to the training room in the Bruins locker room. It was a pig pen, but that's okay. For years, we took care of all kinds of lacerations and never had a single wound infection, even though the conditions were hardly ideal. But in any case, that was my first experience. And this guy had taken a skate across the face from the cheek down across the maxilla, across the upper lip, down across the lower lip, down the chin and onto the neck. Fortunately, not deep, but it was right down, right to bone in the mandible. So you could put your finger in and feel it. And the orthopedic surgeon, who was he was the team doctor, he wanted my advice as to whether anything needed to be done. Was there anything wrong with the jaw? No, the answer was no. But I'm thinking my experience had always been hockey injuries. You sew them up and they go back to play. But here was something that if they come into the emergency room, you clearly would have admitted the patient and taken them to the OR to fix. But no, we just went ahead and we started fixing it there. We sutured. He started one end, I started at the other, and we sutured for a good hour, putting everything back together. The next day, the newspaper said, so one of the headlines was "Galley survives face-off," which I thought was pretty cool. He years later introduced me to someone. Yeah, here's the doctor put my face back on. So but that was my introduction. I got a call from a reporter for the Associated Press one time. He was wanted to do a story about hockey injuries, and he said to me, "Well, was that the worst hockey injury you've ever seen?" I said, "Well, I guess it would qualify, but it was my first." And never heard anything more from that guy. He never wrote the article. But that was that was a lot of fun. I got to know the players, got to know the training staff and the coaches, and they were a fun group of people. Not at all the kind of stereotypical people you say, "Oh, those hockey goons." They're just goons. In fact, a lot of them were very well educated. One of my lasting memories, I may have told you this one before. One of my lasting memories is being in the Montreal Forum, where we used to get to travel when it was playoff time. We got to travel with the team. So I was in the Montreal Forum. In between the first and second periods, when everybody thinks they're in the locker room, just getting all fired up and they're yelling and screaming, and what are they going to do, and how going to get this guy the next period? No, nothing like that. I walk into the locker room, and over in one corner, there's one of the guys sitting with another one, explaining. He's got the latest issue of Scientific American. He's sitting there explaining to this guy the Big Bang Theory in a totally dispassionate way. None of the fans are going crazy up in the stands, but down in the locker room, no, nice and quiet. Everybody's just doing their thing. Totally different from what you think of as hockey goons. They weren't goons at all. They were very, very, most of them, very good guys. One of the guys who was one of the enforcer types for the Bruins, one of the guys that his job was to go out and start fights. He subsequently went to Harvard Business School. Once he got through being a hockey player, he wasn't a fighter. It wasn't his mode of living. He went to Harvard Business School. So a lot of these guys did things off the ice that the fans had no idea about. But I got to know them. I got to be friendly with a number of them. And it was a lot of fun. It was one of the most fun things out of pure oral surgery that I did. It was related to oral surgery, but it was still not oral surgery. It was just fun time.
Yeah, that's actually fascinating. And